Okay, chapter 27, we have four more learning goals we got to cover: the electrolyte balance, the pH balance, pH imbalance, and finally development and aging across the life cycle and how that affects fluid balances, pH, electrolyte balances, and kind of how that all works together. So we're going to start off talking about electrolyte balances. And first of all, we have to kind of understand a few basic concepts around that. So electrolyte gains and losses have to be equivalent, or we mess up homeostasis, right? So we need to have a total electrolyte concentration that helps to maintain fluid balances, like we talked about before. The kidneys, if you have increased amounts of solutes, you're going to pull more water in the regions of the kidney where we're helping to maintain osmotic pressure in our body fluid compartments. And then we have to talk about the individual concentrations of different types of electrolytes and how those are balanced, because that really dramatically affects cell function. For example, if your potassium levels are low, it can be very serious, or if your potassium levels are too high, it can be very serious. So individual electrolytes have very specific effects depending on how important they are for cellular function. Sodium is the dominant solute in extracellular fluid, and it makes up for about 90% of the osmotic concentration in the extracellular fluid, not necessarily as sodium by itself, but sodium salts like sodium chloride or sodium bicarbonate. Those are the main solutes that help to maintain the osmotic pressure in extracellular fluid, which of course is what the kidneys are interfacing with in terms of the filtration that occurs, because extracellular fluid is very similar to plasma. Plasma is what makes the filtrate in the kidneys. So this is kind of a continuation of understanding what we talked about with the kidneys in the previous chapter. Electrolytes are measured in what we call equivalents or milliequivalents. An equivalent is the amount of charge in 1 mole. So negative or positive. It's a mole of electric charge. So remember how we talked about in chemistry, 1 mole is 6.02 times 10 to the 23rd particles. In this case, it's 6.02 times 10 to the 23rd charges. That's an equivalent. So if you have an electrolyte like sodium, which is just positive 1, then you'd have 1 mole of sodium would be 1 equivalent of electric charge. But if you have calcium, which is a positive 2, right, you'd only need half as much or half a mole of calcium to have an equivalent in terms of charge. Okay, so just to help us kind of understand that, it's not the actual number of particles, it's the amount of charge that those particles carry that makes an equivalent. So normal sodium concentrations are about 140 milliequivalents, which is 1,000th of an equivalent is 1 milliequivalent. So if you have 140 milliequivalents is the amount of sodium that is present in extracellular fluid. In intracellular fluid, on the other hand, it's only 10 milliequivalents. So far more sodium in extracellular fluid than there is in intracellular fluid. Potassium is the dominant cation in intracellular fluid, and its concentrations inside the cell are about 160 milliequivalents, and then in the extracellular fluid, it's only 3.5 to 5.5 milliequivalents. So potassium, think intracellular, important cation. Extracellular fluid, think sodium is the most important cation. The most common problems for electrolyte balance are caused by imbalances in sodium, because it's extracellular fluid is what interfaces with the environment the most, and so it's there's a lot of fluctuation in our sodium levels, and so that can cause problems for sure, but they're usually something that we can fix fairly quickly, with our intake or changes in the way the kidneys are filtering it out or reabsorbing it. I remember how aldosterone and antidiuretic hormone directly started to impact that and help to regulate sodium levels. So while they're the most common problem, we also have lots of solutions for it, and they don't usually become very serious. However, potassium levels, while less common in terms of imbalances, are much more dangerous than sodium imbalances. And the reason for that is, if you will recall, going way back to when we talked about the electrical gradients across cell membranes and what makes a cell excitable or not, the resting membrane potential of a cell, is closer to the equilibrium with potassium versus the equilibrium with sodium. So if you mess up your potassium levels, the cell's basic resting membrane potentials are going to be affected, and that, of course, is hugely problematic for muscles and nerve tissues, right? So you don't want to have a sudden problem there, because then your cardiac muscle's not working properly, your neurons aren't working properly, therefore your brain isn't working properly. It's very, very critical, right? So potassium balances are crucial to cellular function because of the fact that they are the main cation for intracellular fluid, and they're responsible for maintaining resting membrane potential. Okay, where are we here now? Sodium, let's talk about that now specifically. The total amount of sodium in extracellular fluid represents the balance between two basic factors: how much we take in through the digestive system versus how much we excrete in our urine and in our perspiration. So those are the two main ways we lose it: urine and sweat, and we take it in through the diet or through our diets. A typical gain or loss of sodium throughout the day would be between 48 and 144 milliequivalents, or about 1.1 to 3.3 grams of actual sodium in a day. If those gains exceed the amount that we lose, then we have a increase in sodium in the extracellular fluid. If those losses exceed the gains, then we're going to have a decline or a reduction in the sodium levels in the extracellular fluid. And that is what is going to stimulate osmoreceptors here in our hypothalamus. Once those are stimulated, now you have antidiuretic hormone that is secreted into the posterior pituitary. That directly affects the kidneys. And the kidneys will, remember, at the distal convoluted tubules, they're sensitive to ADH, and they're going to start reabsorbing more sodium. Water follows sodium, so therefore the kidneys reabsorb more water. Also, the hypothalamus helps to stimulate thirst centers in the brain, so that we're going to be drinking more and bringing in more fluid that way. So if there's increased levels of sodium, we'll be drinking more fluids. Drinking more water helps to bring that concentration down, because we have more water in the system, and sodium then is more dissolved or more dilute. Also, because the extracellular fluid, the osmolarity there is increasing, water is going to shift from the intracellular compartment into the extracellular compartment, and that also helps to decrease sodium concentrations. So all of those factors, the kidneys drinking more and your intracellular fluid providing more fluid to the extracellular fluid, is going to overall decrease the concentration of sodium and bring it back to normal levels within the extracellular fluid. Okay, when the opposite occurs and sodium levels are decreasing, okay, or the amount of concentration of sodium is going down, osmoreceptors in the hypothalamus are inhibited. That decreases the amount of antidiuretic hormone that is produced. The kidneys now allow more fluid loss. Thirst is suppressed, so you're not drinking as much. Water loss by the kidneys increases, so we're going to be peeing more. Water loss decreases the extracellular fluid volume then, and the osmolarity is going to come back up in terms of sodium concentrations, and so that's going to restore the homeostatic balance of normal sodium levels, which again is about 144 milliosmoles. So to maintain homeostasis, we have to maintain a normal volume of extracellular fluid. Again, extracellular fluid is, plasma is part of extracellular fluid, so we can indirectly measure the volume of extracellular fluid based on blood pressure. So that's how we can sort of maintain better homeostatic volumes for extracellular fluid via sensing blood pressure. So cardiac muscle cells notice a lot when our blood volume goes up because there's going to be some stretch in the atria and the ventricles. So they release natriuretic peptides. Okay, so you have atrial natriuretic peptide, ANP, and then you have B-type natriuretic peptide, or BNP, which is secreted by the ventricles. Those are released, okay? They affect the hypothalamus, the kidneys, and the blood vessels. The way they affect the hypothalamus is to sort of suppress the ADH and aldosterone secretions. We want to inhibit those things, and we increase the loss of sodium in the urine. We increase water loss in urine because, of course, water follows sodium. So if you have more sodium secreted, you're going to have more water loss. And we're going to inhibit, like I said, ADH and aldosterone, epinephrine, norepinephrine release. All of those things are inhibited a little bit to help reduce the strain on the heart muscles. And then peripheral vasodilation occurs, which helps to decrease blood pressure. Okay, so that is going to then restore the normal extracellular fluid volumes via controlling blood pressure and monitoring blood pressure. Okay, so the opposite situation where we have a decrease in extracellular fluid is picked up right away because the baroreceptors in the kidneys are going to notice that. So when we have a decrease in extracellular fluid, we have a decrease in plasma as well, right? Because remember, plasma is part of the extracellular fluid. So if you have a decrease in extracellular fluid, you're going to have decreased volume in your plasma and your blood. So your blood pressure is going to go down, and that is picked up by those baroreceptors in the kidneys, those juxtaglomerular cells. That's going to promote sympathetic activation of the heart and the blood vessels. It's going to promote the hypothalamus getting activated and releasing more antidiuretic hormone. It's going to directly secrete renin, and those juxtaglomerular cells are going to secrete renin, which helps with the conversion of angiotensin 1 to angiotensin 2, and that's going to promote aldosterone release. And the outcome of all that is you're going to have a decrease in sodium loss in the urine, a decrease in water loss in the urine, because remember, water follows sodium, and then you're going to have increased thirst. You're going to increase the volumes that way of fluid in the extracellular compartments through the digestive system. And then you're also going to increase cardiac output and peripheral vasoconstriction. So all of those things contribute to a restoration of extracellular fluid volume and plasma volume, and blood pressure, right? So the more volume you have, again, your blood pressure is going to be restored. So the baroreceptors indirectly measure the volume by measuring the pressure, and by increasing the volume, we restore the pressure. Then the two things then that can occur are the hyponatremia, which is low sodium levels, and that will be measured in lower than 135 milliequivalents per per liter of sodium in the blood tests. Okay, and for hypernatremia, it occurs with dehydration usually. And that would be when sodium concentrations go above 145 milliequivalents per liter. So that would be hypernatremia. And then hyponatremia is when you've had too much water and you've actually dissolved the sodium levels to the point where they're under 135 milliequivalents per liter. Okay, potassium. So we also have to regulate potassium levels very, very carefully. In fact, potassium regulation is sort of indirect because it's as a consequence of sodium regulation. And if we get an imbalance of potassium, if it's too extreme, again, above this 7 milliequivalents, you have hyperkalemia. And if it's below 2 milliequivalents per liter, you have hypokalemia. And both can lead to really serious conditions. As you can see here, if you have hyperkalemia, you can have cardiac arrhythmias, which can be fatal. When your potassium levels are too low, you end up with weakness and then paralysis, and eventually your heart would just stop because you need to have those potassium levels regulated carefully in order for the cell membranes to have any potential electric difference, right? And so if those levels are not maintained, then you end up with cells and nerves, or muscle cells and nerve cells that don't work. So obviously that's an important thing to have working. Okay, so the reasons, excuse me, the effects on potassium are in terms of intake. We get it from our diet. We can have, we need to get at least 50 to 150 milliequivalents intake per day. That's about 2 to 6 grams of potassium. And we need to have things like our pH balance and our kidneys functional in order to maintain those levels. So if you have chronically low pH or chronically high acidity in your body, you're going to be pumping hydrogen ions out. And if you remember from earlier in our chapter, we looked at the sodium potassium pumps and also the sodium hydrogen ion pumps. So if we're trying to get rid of hydrogen ions instead of in order to bring in sodium, we're not going to be utilizing the sodium potassium pumps as much. So we're going to be retaining potassium while we're trying to excrete hydrogen ions instead. So again, pH affects the concentration. So you could end up with hyperkalemia if you were too acidic. So that's one of the reasons that things like acidosis is a problem and can lead to really serious conditions. Kidney failure, obviously, if your kidneys aren't working, you're not going to be able to secrete the potassium because that's the only way we get rid of potassium. And then certain drugs can block those sodium potassium pumps and cause hyperkalemia. So that's something to be very careful and watch for with medications. On the flip side, with the hypokalemia, if you have diuretics where you're increasing the urine volume considerably, you are losing more potassium as a result of that. And also, if you have aldosteronism, which is an endocrine dysfunction where too much aldosterone is produced, the distal convoluted tubules in the kidneys are going to be pumping way more sodium in and way more potassium out and can lead to hypokalemia. All right, I think that covers it. Yes. So one thing too with aldosterone is if you get higher, in a normal functioning endocrine system, if your potassium levels are starting to go too high, aldosterone will automatically be secreted as a way to balance that out. So that's one way we can kind of regulate at least hyperkalemia. So here you can see, go ahead and pause it and kind of read these through if you'd like, the conditions that occur with hypernatremia or too much sodium over 145 milliequivalents per liter, or hyponatremia where you have below 135 milliequivalents per liter. And the signs and symptoms for hypernatremia would be that thirst and reduced blood pressure. For hyponatremia, on the other hand, it's like water intoxication, and you may have heard of this. It's going to be very serious with CNS disturbances, confusion, hallucinations, and in severe cases, it can be fatal. So the treatments for that would be to have, obviously increase your sodium intake or decrease the sodium intake by introducing more water, either by IV or just by drinking it. Potassium, you have hyperkalemia, very severe cardiac arrhythmias and muscle spasms can be a result of that. And it's usually caused by things like renal failure or too many diuretics. And then the solution would be to increase a hypotonic solution and kind of dilute that high level of potassium. Hypokalemia, you have muscle weakness and paralysis, which could lead to a fatal outcome as well if it's not corrected. And so you need to get some potassium, either through dietary potassium or infusions. Okay, I'm looking now at calcium. Calcium is one of the most abundant minerals in our body. We have 1 to 2 kilograms of it, mostly stored in our skeletal systems. If you have, the right levels of calcium, it's absolutely crucial to nerve and muscle function. Remember how we talked about calcium being released from the terminal cisternae in the muscle cells, and that's what allows for the whole sliding filament theory to occur. It starts with the calcium release into the intracellular fluid. And then also for nerve function, in order for the neurotransmitter vesicles to fuse with the presynaptic membranes, you have to have infusion of calcium. So calcium is crucial to both of those types of cells and their function. Blood clotting, it's important for, and also for it's a cofactor in many different enzymes and reactions that occur inside the cells, as well as a second messenger for various cellular metabolic functions. So the main regulators for calcium are the parathyroid hormone and calcitrol. Those help to raise calcium concentrations by increasing the amount that we release from the skeletal system. And then calcitonin, on the other hand, which is released by the thyroid, opposes that. So it decreases the amount of calcium in circulation. So it helps to encourage storage of calcium in the bones. We gain calcium mostly through our dietary intake, and we can also reabsorb it in the kidneys, and that's under the stimulation of PTH and calcitriol, which wants to increase blood calcium levels. Calcium is lost in bile, urine, and feces in usually very small amounts, less than 1 to 1.2 grams per day, and it represents only about 0.03% of the entire calcium reserve that we have in our bodies. Hypercalcemia leads to problems with muscles, as you can imagine. Kidney stones and other types of issues with our soft tissues actually calcifying, particularly in areas where you've had injuries. It's a problem. Causes can be things like hyperparathyroidism and cancer, or vitamin D toxicity, or maybe just too many supplements of calcium. And so in order to reduce that, we have to infuse hypotonic solutions that help to lower those calcium levels, or actually remove the parathyroid in case of parathyroid issues. Hypocalcemia, which is less than 4.3 milliequivalents per liter, can also lead to muscle spasms, convulsions, weakness, cramps, certainly osteoporosis, because that's taking too much calcium out of the bones. And causes would generally be a poor diet, not enough vitamin D, because vitamin D is crucial for calcium absorption, renal failure, hypoparathyroidism, or hypomagnesium. So calcium supplements and vitamin D supplements are the solution to that. Now, magnesium. So magnesium balance. In an adult, we have about 29 grams of magnesium. 60% of that is stored in our skeleton. Magnesium has a charge of +2 in the body fluids, okay, and it's primarily in the intracellular fluid. It's required as a cofactor for many different enzymatic reactions, things like phosphorylation of glucose, which is one of the first steps in breaking down glucose in the glycolysis cycle. So you need magnesium for that. And then we use magnesium is used for ATP production and contracting of muscle fibers, so very important there. It's usually reabsorbed by the kidneys, and our daily requirements are about 24 to 32 milliequivalents. Phosphate, or PO4, is a polyatomic ion that is really important for our electrolyte balance as well. Most of it is required for bone mineralization. We have about 740 grams in our minerals in the skeleton. In the intracellular fluid, it is required for the formation of high energy compounds like our nucleic acids and ATP. Plasma concentrations are usually between 1.4 and 1.8 and 3. So you can see here, if you have more than 3, you have hyperphosphatemia, phosphatemia, and then if it's under 1.8, then you have hypophosphatemia. So really important to maintain those. Symptoms for hyperphosphatemia are not really immediate, but you can have chronic elevation, and that can lead to calcification in soft tissues. I see that as a physical therapist sometimes in tendons, and that can be a real problem with reducing your range of motion and stuff. Causes are just too much intake in our diet, and so treatments are to reduce that or to increase your parathyroid hormone supplementation. And then hypophosphatemia is not getting enough in your diet, so you can end up with anorexia or loss of appetite, dizziness, muscle weakness, etc. And the solution obviously is to just get a little bit more of it in your diet, and also to supplement with vitamin D to help with absorption of phosphate. And then chloride, you need plasma concentrations between 100 and 108 milliequivalents would be the normal range. It's the most abundant anion or negatively charged ion in the extracellular fluid. Intracellular concentrations are usually really low, less than or around 3 milliequivalents per liter. And then chloride is absorbed across the digestive tract with sodium, and it's reabsorbed with sodium along the renal tubules as well. If you'll recall, in that loop of Henle, the ascending thick loop of Henle, we are reabsorbing or secreting sodium and chloride into the extracellular fluid there. And usually we lose about 48 to 146 milliequivalents, or 1.7 to 5.1 grams per day. And as you can see here, hyperchloremia can lead to acidosis or hyperkalemia. And we talked about what the effects of acidosis on hyperkalemia are. And then dietary excesses of chloride is the cause of that usually. And then the treatment would be to use a hypotonic solution to help dilute that. Hypokalemia can lead to alkalosis, loss of appetite, and then muscle cramps. Vomiting and hypokalemia are usually the causes of that. And diuretic use of infusion or hypotonic salt solutions can help to restore the balance there. Okay, so in talking about pH balance, we have two sort of extremes, and that would be acidosis and alkalosis. So our normal pH range is from 7.35 to 7.45. If we go below 7.35, that is considered acidosis, even though that pH is actually more alkaline. It's not, it's higher than neutral. It's still an acidic condition for a human being because we are normally more alkaline than that, right? So we still consider it acidosis, even if it is slightly alkaline in terms of the actual pH reading. There are drawbacks, obviously, to both alkalosis and acidosis. Both can be extremely problematic if they're not corrected. But it's more common for us to be in a state of acidosis. And the reason for that is that we produce a lot more acids in our basic metabolic functions than we do more alkaline substances. So there's three classes of acids that generally affect our pH. There's fixed acids that are byproducts of protein metabolism, amino acids, and nucleic acids too. Sulfuric acid and phosphoric acid are those type of acids, and they usually are excreted by the kidneys. Metabolic acids are those that are produced oftentimes with either glucose metabolism or fatty acid metabolisms. So if you're, remember back when we talked about glycolysis, pyruvic acid is an end product of glycolysis, and lactic acid is produced from pyruvic acid if we don't have enough oxygen present. So in anaerobic metabolism, you have a lot of pyruvic and lactic acid production. And in the case of a low carb diet, you have a lot of ketones that are produced because you're burning fats for energy. And so all of those are synthesized from acetyl coenzyme A, which you will recall is part of the citric acid cycle. So buildup of those metabolic acids is usually not a big problem. Usually we metabolize them pretty quickly. So for example, if you are in an anaerobic exercise program for a while, you have some sore muscles, but usually that is all metabolized and you're okay within a few days. And volatile acids are those that leave the body by entering the atmosphere as a gas in the lungs. So carbonic acid is a volatile acid that will break down into carbon dioxide and water and carbon dioxide can be excreted in the lungs. So this is this equation that we've looked at a few times. It's one of the main things that helps to buffer pH in our blood. Carbonic acid is formed from carbon dioxide and water, in the tissues when they're producing those as end products from metabolism. And then the carbonic acid dissociates fairly rapidly into hydrogen ions and bicarbonate ions. The hydrogen ions can be excreted through the kidneys, and then the bicarbonate is usually retained in the blood plasma, where it helps to buffer additional hydrogen ions. So that's it for those three main classes of acids. Okay, so carbonic anhydrase is an enzyme that forms carbonic acid in the cytoplasm of red blood cells in the liver and in the kidneys, and in parietal cells in the stomach, and many other cells as well. So carbonic acid is formed in lots of places, again, from water and carbon dioxide, and then it dissociates into the hydrogen ions and the bicarbonate ions, sorry. So homeostasis, if you imagine it kind of here as this little teeter-totter in the cells where we're producing lots of carbon dioxide, we tend to have increased carbon dioxide and the pH is going to go down. We're going to have a more acidic condition in the tissues as carbon dioxide is produced. So then right away, carbonic anhydrase is going to form the carbonic acid, which then dissociates into hydrogen and bicarbonate. Bicarbonate ends up as a buffer, and the hydrogen ions are hopefully excreted in the kidneys. So as you can see, the partial pressure of carbon dioxide here is the main driver of pH. So as the partial pressure of carbon dioxide goes down, for example, in the lungs, where we're excreting or exhaling the carbon dioxide, then the pH is going to go back up, right? Because this is going to drive the reaction the opposite direction. So hydrogen ions are going to be absorbed by the bicarbonate, form carbonic acid, and then we're going to release the carbon dioxide, and that just leaves us with water, right? So it's going to, again, rebalance the pH. Okay, so in order to help prevent extremes of acidosis or alkalosis in our systems, we have to have a buffering system. And buffers are usually weak acids or weak bases that can help to absorb extra hydrogen ions or release extra hydrogen ions as needed. The way we decide if an acid or a base is weak depends on how readily it disassociates in water. So if it disassociates completely, it's considered a strong acid or a strong base. If it doesn't, if sort of resists disassociation in solution, it tends to be a weaker base or a weaker acid. So there's three major buffer systems inside the cells or in the intracellular fluid. You have the phosphate buffer system and the protein buffer system. And in the extracellular fluid, you have more of the protein buffers as well as the carbonic acid bicarbonate buffer system that we've talked about before, with the carbon dioxide and water forming carbonic acid when carbonic anhydrase is present, and then dissociating into bicarbonate and hydrogen ions. So that's that system. The phosphate system, you have a weak acid and a weak base. So the weak acid is hydrogen phosphate and the weak base is sodium phosphate, and they help to absorb or release hydrogen ions depending on the pH in the solution, and that helps to kind of keep it around that neutral system for us. The protein one we're going to look at in the next slide, and then we've talked about quite a bit about the other carbonic acid system here too. So I'm just going to move on to so here's how the protein buffer system works. You have the amino acid here, and the carboxyl group on this end here. When the pH decreases, okay, we have so much extra hydrogen floating around, it acts like a little sponge, and some hydrogen ions can be absorbed here on the nitrogen end of things, and in the carboxyl group we can absorb a hydrogen, and then sometimes that R group can absorb a hydrogen. So you end up with kind of being like a little sponge, soaking up the extra hydrogen. So it acts as a weak base and absorbs hydrogen. If the pH increases and gets too alkaline, on the other hand, then it acts as a weak acid and it releases hydrogen ions into the solution. So it helps, again, to pull the solution back toward neutral. Back toward neutral. When the amino acids are in a peptide bond, then these areas are already bound to the other amino acids, so then the R group itself has to act as the buffer. If it's already in a protein, if it's just a single amino acid, though, then the carboxyl groups and the amino groups here can act as a buffer as well. So we can use respiratory compensatory mechanisms in order to get these hydrogen ions from metabolic and fixed acid sources out of the body, right? So when those hydrogen ions are dumped into the blood plasma, we can draw from the sodium bicarbonate buffers and disassociate those, create the get the bicarbonate out of there, bind that with the hydrogen ions, get carbonic acid. Carbonic acid then disassociates into carbon dioxide and water. So these hydrogen ions get associated into water molecules, and the carbon dioxide gets exhaled. So this is a respiratory compensatory mechanism for increased acidity in the extracellular fluid. The carbonic acid bicarbonate buffer system at work. And the other way that can be done is in the renal system, so we'll look at that here next. So the kidneys have three main buffer systems that are pertinent to the filtrate here. In the glomerular filtration, you get the factors for the carbonic acid bicarbonate buffer system and the phosphate buffer system, and then the proximal convoluted tubular cells produce the ammonia necessary for the ammonia buffer system. So, and you can see here the net result of this is that you have more hydrogen ions pumped out, sodium ions and chloride ions pumped into the cell. And the filtrate then is going to be helping to excrete excess hydrogen ions. Here's just showing in the PCT what's happening here. When you're breaking down glutamate, you produce the extra ammonia. The ammonia is pumped out, so sodium can get pumped in, and that helps to reduce pH because you're getting rid of hydrogen ions in the ammonia complex. And then in the case of alkalosis, we're actually able to pump bicarbonate out and chloride into the cells and the bicarbonate out into the filtrate. So this helps to reduce the pH again as needed in the case of alkalosis. Okay, so this is labeled wrong. This is supposed to be the response to alkalosis caused by the decrease in hydrogen ions. So that's a poor title there. But so what happens is if you have too low, like we've removed too much hydrogen ions, the respiratory rate is going to decrease, right? So that's going to increase the partial pressure of carbon dioxide. So more carbon dioxide and water is going to be combining to form carbonic acid. That disassociates to form some hydrogen ions, which is important because we want to increase the number of hydrogen ions in order to reduce the alkalinity of the system. And bicarbonate ions are going to be moved into bicarbonate reserve, combining with sodium. And then the kidneys do generate hydrogen ions as well by reabsorbing them from the filtrate and helping to secrete bicarbonate ions. So all in all, this is going to combine to increase the hydrogen ion concentration in the plasma and restore the pH, reduce the alkalinity, and increase the acidity. So when we have prolonged or extreme changes in the pH in our systems, it can be very serious. It can lead to, we use up all the buffers and our respiratory system can't compensate or our renal system can't compensate anymore. That can lead to cardiovascular problems, heart failure, and severe effects on the central nervous system. So we want to avoid that at all costs. There are very serious abnormalities that have acute and then chronic phases. So you can have respiratory or metabolic acidosis, respiratory or metabolic alkalosis, and they can each have acute or chronic compensated phases. So acute is when the pH is rapidly out of the normal range, and then in a more chronic situation, the pH may be compensated for, but the underlying condition still persists. So let's look here first at respiratory acidosis. And respiratory acidosis is when the partial pressure of carbon dioxide increases due to hypoventilation, something like sleep apnea or something along those lines, where you're not breathing deep enough and frequently enough. So when the partial pressure of carbon dioxide goes up, the chemoreceptors in the arterial and cerebrospinal fluid are stimulated, and that increases the respiratory rate. Centers in the medulla boost the respiratory rate. The pons as well has respiratory rate connections. Then the kidneys are stimulated to secrete more of the hydrogen ions and to absorb more bicarbonate ions. So the buffer system then can work a little bit more effectively. We're getting rid of hydrogen ions, bringing on bicarbonate ions, and then the carbonic acid bicarbonate system helps to absorb additional hydrogen ions. That's going to then decrease the carbon dioxide, partial pressure of carbon dioxide, decrease the hydrogen ion concentration, and increase the bicarbonate concentration, which results in bringing the pH back up and restoring the normal levels. So again, that would be a reaction to acute respiratory acidosis. So here's another situation that can occur with hyperventilation. You can actually be exhaling out too much carbon dioxide. So when the partial pressure of carbon dioxide goes down too much, it's going to increase the blood pH, and arterial and cerebrospinal fluid chemoreceptors are actually inhibited. That means that the kidneys generate the hydrogen ions and secrete bicarbonate, so they reverse their process. The buffer systems, other than the carbonic acid bicarbonate buffer system, release hydrogen ions. So those proteins that we talked about, the protein buffer systems and stuff, they start to release the hydrogen ions back into circulation, and that decreases the respiratory rate, and that brings about an increase in the partial pressure of carbon dioxide, an increase in hydrogen ions, and a decrease in bicarbonate ions, and that brings the pH back to normal. Okay, so you have a pH that is going too high, and this helps to bring it back down. So here we're also looking at a slightly different mechanism, but we're looking at a loss of hydrogen ions and a gain of bicarbonate can lead to metabolic alkalosis, or an elevated pH. So if you have a decrease in the hydrogen ions or an increase in the bicarbonate, you're going to increase the pH in the blood. The receptors, the arterial receptors in the central cerebral spinal fluid, chemoreceptors, are going to be inhibited in this case. The kidneys are going to start to generate hydrogen ions and secrete the bicarbonate. So we're going to try to reabsorb hydrogen ions and bring the acidity back up, or the pH down. Buffer systems other than the carbonic acid buffer system release the hydrogen ions, and you have a decrease in the respiratory rate. That helps to increase the partial pressure of carbon dioxide, increase hydrogen ions, and decrease the bicarbonate ions. That helps to bring the pH back to normal, or actually bring it down to become a little bit more acidic, and then it restores the normal blood pH. So a patient comes to you, they have some symptoms of any one of these conditions we've talked about: acidosis, alkalosis, etc. So you want to check and figure out what's going on. So first you draw an arterial blood gases. So you're going to take some blood, not from venous blood, but from arterial blood. So you usually have to go into the radial artery and very carefully get some blood out that way. If you check the pH and you find out that it is below 7.35, then it's considered an acidosis situation. Next, you're going to check the partial pressure of carbon dioxide. So if it's metabolic acidosis, the partial pressure of carbon dioxide can be normal or decreased. The respiratory alkalosis, you're going to have an increase in partial pressure of carbon dioxide. So normally it would be greater than 50 millimeters of mercury. So that's an increased partial pressure of carbon dioxide. The primary cause for this is hypoventilation or insufficient respiratory volumes and rate. So next you're going to check the so let's say it is increased, right? Your partial pressures of carbon dioxide are increased, so we know it's a respiratory acidosis in that case. So next you're going to check the levels of bicarbonate, and if the bicarbonate is increased, we know we have a chronic compensated for acidosis. So examples would be emphysema or asthma. If it's acute, the bicarbonate levels may be normal, and you're going to have things like respiratory failure or central nervous system damage or pneumothorax, things that were more traumatic or just recently happened, and it hasn't yet compensated for the acute respiratory acidosis. Okay, so going back here though, let's say that the the partial pressure of carbon dioxide was normal or slightly decreased rather than increased. So then we know that this is going to be a metabolic acidosis, right? So if it's metabolic acidosis straight up, you're going to have normal partial pressures of carbon dioxide. If it's chronic, you might have decreased partial pressures of carbon dioxide, which is a reduction due to the respiratory compensation. So we're trying to reduce the acidosis by increasing our respiratory rate, so we'll actually have lower than normal carbon dioxide levels as we try to compensate for the metabolic acidosis. So the next thing we're going to check is the anion gap. Okay, the anion gap is due to the sodium concentrations, where we're trying to pump out bicarbonate and chloride concentrations. So the anion gap is to look at the sodium concentration minus the bicarbonate concentration plus the chloride concentration, and that helps us to see how much in terms of more anion there is than sodium, and that gives us good information. So if it's normal due to a loss of bicarbonate or to the generation of or ingestion of hydrochloric acid, an example would be like diarrhea. Okay, so you'd have normal bicarbonate and normal anion gap. If the anion gap is actually increased, okay, this would mean that the generation or retention of metabolic or fixed acids is occurring, and we'd have lactic acid ketoacidosis or chronic renal failure would be your diagnosis. Okay, so again, if the pH is below 7.35, you know you have acidosis. So next you're going to check carbon dioxide, partial pressure of carbon dioxide in the arterial blood. Then you're going to be able to kind of follow this chain through to see if it's acute or chronic, and if it is, then you know what to do. Okay, so on the other hand, if you check the pH and it is higher than 7.45, then now you know you have alkalosis. So the next thing you're going to do is check the partial pressure of carbon dioxide again. If the partial pressure of carbon dioxide is increased, greater than 45 millimeters of mercury, it means the carbon dioxide levels are elevated, and that could occur in the case of vomiting or loss of gastric acids. Those would be metabolic causes for alkalosis. If the partial pressure of carbon dioxide is decreased, now you know you have a problem with the respiratory system, and your primary concern comes from hyperventilation, where you're breathing too rapidly. So the next thing you're going to check is the bicarbonate level And if the bicarbonate level is normal or slightly elevated, then you probably are dealing with respiratory alkalosis. And an example would be a fever or a panic attack. Chronic compensated for respiratory alkalosis is a little different. You have decreased bicarbonate because we have a little bit of acidity going on, right? And your explanations or examples would be things like anemia and central nervous system damage. So that's, the way you would be able to kind of go through and decide whether or not this is acidosis or alkalosis, and then whether it's respiratory or metabolic, and then you can decipher also if it's acute or if it's compensated for as a chronic condition. So essentially, as we age, we're going to talk about how that affects fluid balance, electrolytes, etc. So starting off as young babies, we have up to 70% of our bodies as water, and then that as we age, we just continue to dehydrate. So up to age 40, it's like 50 to 60% still of body weight is water. As you get up to that 40 to 60 years of age, men drop down to about 55% water and women down to about 47%. Over age 60 now, men are like 50%, women down to 45%. So basically, it's just a continuation. You dehydrate as you age. Some of the consequences of that are that we have less fluids in our body to dilute things like toxins and other drugs and things like that. So those things that get into our body are in a more concentrated solution. This messes up our glomerular filtration rates, and the nephrons aren't functioning as well. So our ability to regulate pH in terms of renal compensation goes down. We also can't concentrate our urine as well, so you're going to have higher polyuria, or you're going to be peeing more. Insensible perspiration also increases because our skin is thinner and less waterproof. So it's harder to maintain daily water intake sometimes as we age as well. Our reductions in ADH, or antidiuretic hormone, makes it easier to lose more water. So again, it's harder to stay hydrated. Muscle mass and skeletal mass is going down, which causes less mineral content in our bodies as well. We can compensate for some of that by working harder at being hydrated and exercising more to help keep up our lean body mass, and we can also help to supplement with minerals and nutrients in our diet. So also the rest, so renal compensation for acidosis or alkalosis goes down, but then so does respiratory capacity as well. So your vital capacity or your ability to breathe as well goes down. So you're going to be more apt to hypoventilation, and so that increases your risks of respiratory acidosis as well. So arthritis and emphysema and things like that really aggravate those conditions, and that can lead to further disorders in other major systems of the body. So basically, if you can try to stay as hydrated as possible and as active as possible late into life, you help to avoid some of the seriousness of these conditions. But if you don't, they do become a much more serious problem as we age.